Hi, I'm Diane Rittenhouse. I'm a family physician and senior fellow at Mathematica and a professor of family medicine and health policy at UCSF. And I'm so honored to be hosting this roundtable today on implementing high quality primary care in California. We have a large and diverse audience today, people from across California and across the country. And I'll just say that if you are passionate about primary care, then you are in the right place. Our overall agenda is simple. I'm going to talk for a minute about California, and then we're going to be introduced to a new report on primary care. And then I'm going to introduce the participants of our roundtable today, and we're going to engage in a discussion, some of which is stimulated by the questions that many of you submitted during the registration process. We will have at the end a live Q&A time, so if folks can enter their questions using the Q&A widget at the bottom of your screen throughout the session, that would be really helpful to us. So let's get started. Because we're not here to talk about primary care for primary care's sake, but instead primary care for the people of California and how it can make their lives better, let's talk for a minute to do some level setting about California. I'm going to share with you some fun facts. California recently surpassed the UK and is now the 5th largest economy in the world. We are the most populous state. 1 in 8 US residents lives in California, which is over 39 million people. Over a quarter of Californians were born outside of the US. A majority of recent immigrants come from Asia. And there is no race or ethnic group that constitutes a majority of the population of California. The largest ethnic group is Latinx, which comprises about 40% of the population of California. 94% of the population lives in 6% of the land area that's considered urban, and we have 2 million Californians living in rural areas. Because of the high cost of living, more than a third of Californians live in or near poverty, and there's wide variation in the poverty rates across the state. On any given night, over 160,000 people experience homelessness in California. From a healthcare coverage perspective, California is one of the Medicaid expansion states. We have our uninsured rate down to 7%. A large part of those that remain uninsured are undocumented. From a Medicaid provider payment standpoint, our rates are the 3rd lowest in the country. California's healthcare delivery system is unique not only in its high level of HMO enrollment, but also in its use of the delegated model, which transfers financial risk and a range of responsibilities from health plans to large physician organizations. And there is wide variation across California's 58 counties in terms of the presence or absence of these physician groups. In fact, a third of all physicians in California are in solo practice, and California has nearly 1,000 federally qualified health center sites. So with that context, let's talk about primary care. I want to start by introducing Dr. Bob Phillips, who's a family physician and the director of the Center for Professionalism on Value in Healthcare in Washington, D.C. Bob is a member of the National Academy of Medicine and served as the co-chair of the committee that issued the primary care recommendations that we're discussing today. And he's going to summarize the report for us with a few slides. Bob?
Thank you, Diane. So this is the report that Diane held up. It's implementing high-quality primary care, rebuilding the foundation of healthcare. And as she said, I think it has a lot of relevance to the citizens and people of California, and particularly how to address health equity. It is the first report from the National Academy, the National Academies of Sciences, Engineering, and Medicine focused on primary care in 25 years. And I'm going to walk through just briefly where we arrived in terms of its recommendations. Before I do that, I want to acknowledge the 19 other people who made up the committee and my co-chair, Linda McCauley, who's the Dean of Nursing at Emory University, who contributed so much to the report. Those highlighted in blue, Molly Cook, Susan Fisher-Owens, Benjamin Olmedo, and Hector Rodriguez, are your fellow Californians who contributed mightily to this report. We had 17 sponsors, people who were invested in the planning and the outcomes of this report, including Blue Shield of California. So I hope this has considerable relevance. Our statement of task is a little unusual for National Academy reports. It certainly was to produce recommendations about how to strengthen primary care and how to inform primary care systems around the world. But it had attached to it an implementation plan requirement that is incredibly unusual for National Academy's reports. So we were not only tasked with making recommendations, but how do we see these being implemented in meaningful ways immediately? In terms of study context, in synthesizing the evidence from more than 6,000 publications, we arrived at these findings: that primary care is still the only part of the healthcare system that results in longer lives and more health equity. It is weakening in the US when it is needed most. And while we have some bright spots in different localities and states, we have not succeeded in implementing it broadly. Part of the reason is how primary care is financed. So while it's more than a third of all visits to the healthcare system and more than half of all outpatient visits, it is less than 6% of all investment in healthcare, compared to specialty care, which is 3 times as much, and hospitals 5 times as much. So we're really under-resourcing the platform where most healthcare is provided and where most citizens and Americans come for healthcare. So the share of total healthcare spending on primary care is decreasing. It's actually declined over the last 10 years, except in the states where they've set thresholds for minimum primary care spending. COVID-19 has certainly amplified the economic, mental health, and social health inequalities writ large, but really have damaged primary care further by not bringing it into the strategies for dealing with pandemics. And some of the meaningful policy changes that we've embraced here during the pandemic, including relaxation of telehealth rules, shows that we can change some of the policies and infrastructure around primary care. We've just been reluctant to do it. So in 1996, when the last report was issued about primary care, the committee first wanted to make sure it had a unified vision for what it was trying to achieve. And our committee did the same thing. So we updated the definition of primary care to say high quality primary care is the provision of whole person, integrated, accessible, and equitable healthcare by interprofessional teams that are accountable for addressing the majority of the individual's health and wellness needs across settings through sustained relationships with patients, families, and communities. And the updating has really focused on the role of teams in delivering robust care without neglecting the fundamentals of relationships and their powerfulness and potency for patients, but also for families and communities. One of the highest level visions that the committee came away with is that of primary care as a common good, not as a commodity, not as just a piece of the healthcare system that those with insurance have access to, because we know we can't compete ourselves to better health equity. So because primary care has high societal value, we need to fix the precarious state that it's in. That means we need public policy for oversight and monitoring, and we need strong advocacy and leadership. The 5 main objectives that we came down to focused on payment, workforce, access, and digital health, but with this wraparound objective of accountability that I'll talk about just briefly. So the payment objective really says that we need to pay for primary care teams to care for people, not doctors to deliver services. So moving away from fee-for-service into blended population-based models that can really support services, not just delivering fee-for-service models. Access is about ensuring that high-quality primary care is available to every individual and family in every community, again, focused on the common good. Workforce is about training primary care teams where people live and work, not just in hospitals where most training happens. About designing information technology that can serve the patients, the families, and the interprofessional care teams, not just about documenting care for billing purposes. And then that 5th accountability objective is about ensuring that high quality primary care is implemented. And it has a focus on a a federal interagency workforce at the secretary level that can work across agencies to make sure that we have a strategy for primary care and we have policies that support that strategy. And we think that that actually has a lot of relevance for modeling in California. So I encourage you to go to the website. The report is lengthy. We have 5 two-page briefs on each of the 5 objectives. We have a lot of material that's boiled down to essentials that gives you a good way to enter the report to find what you're looking for. And if you have any questions, please feel free to reach out to the National Academy's team or to me. Thank you very much.
Thank you, Bob, for that overview. I want to introduce the panel now of primary care leaders and have a discussion of primary care in the California context. So please remember as we go along to use the Q&A function at the bottom of your screen to enter any comments or questions for the speakers. I'm going to do very brief introductions. The full bios are available through the platform. So if you want to read more extensively about people's background and how they've come to be where they are, please go ahead and look that up. I'm going to start by introducing Dr. Pallav Barbaria, who is an internal medicine physician and serves as Chief Quality Officer and Deputy Director of Quality and Population Health Management at the California State Department of Healthcare Services, which is the state agency that funds healthcare services for over 13 million Medi-Cal beneficiaries. Dr. Alice Chen is an internal medicine physician and serves as Chief Medical Officer at Covered California, which is the state's health insurance marketplace established under the Affordable Care Act, where she develops healthcare strategy focused on quality, equity, and delivery system transformation. Catherine Phillips is Senior Program Officer at the California Healthcare Foundation, which is an independent philanthropy in California. Her portfolio includes partnering to manage the California Improvement Network and leading the foundation's efforts to advance primary care. She also supports the foundation's efforts to address California's healthcare workforce shortages. And Dr. Rich Seidman is a pediatrician and serves as Chief Medical Officer at LA Care Health Plan, which is the nation's largest publicly operated health plan serving more than 2.4 million members. Its mission is to provide access to quality health care for Los Angeles County's vulnerable and low-income residents and to support the safety net required to achieve that purpose. Dr. Seidman oversees the medical leadership of the organization and focuses on enhancing access and the quality of care provided through contracted plans and providers. So welcome to our panel today. I want to start the discussion by talking about workforce. In the lead up to today's roundtable, we received a number of questions about primary care workforce. How do we train more primary care doctors to serve the diverse population of California? How do we develop the primary care team and be sure that the team members are practicing at the top of their license? How do we attract more clinicians to underserved areas, especially rural areas in California? And as many people know, in California, we had a couple years ago the Commission for the Future Health Workforce in California, and we've made some progress in this area, right? So this year we had a large budget surplus, and many of the recommendations that were made by the Commission a couple of years ago were implemented, at least in part. We saw funding for community health workers, we saw funding for primary care residency programs, we saw additional funding for the University of California Prime program that trains language and culturally concordant physicians in California, to name a few. But we're still hearing from the front lines that it's hard to recruit and retain medical assistants, for example, to be part of the primary care team. So my question to the panel today is, how is this playing out from your particular vantage point, these issues of primary care workforce in California? Who would like to start? Don't all jump at once.
Right, Diane.
Okay, Rich.
Yeah, so good afternoon, everybody. I'm Rich Seidman with LA Care Health Plan. So it's a great question and an important place to start. From my perspective at LA Care, with more than, as Diane said, more than 2.4 million total members, more than 2 million of which are Medi-Cal beneficiaries, what we see is there's an uneven landscape of access to care, including access to primary care. And in part, as Diane also shared earlier, the reality that California pays the third lowest Medi-Cal rates in the nation leads to a disparity in access, because not all physicians, all providers, healthcare organizations choose to participate in serving Medi-Cal beneficiaries. So it's a challenge we need to address. The inequity in payment leads to inequity in access and outcomes. So that's one thing we observe in the challenge of establishing an adequate network and enabling physicians to maintain panel sizes where they can provide quality of care, including access. The only other thing I'd add is another thing we're seeing is additional consolidation of the healthcare providers. And at least two contributors to that are burnout of the provider workforce and financial challenges at sustaining a primary care practice.
Anyone else want to weigh in on this question of workforce?
Sure. And I just have to preface every panel like this with how much I hate virtual presentations. This whole like, oh, who's going to go next? All right, I've got it out of my system. In terms of vantage point, you already mentioned, Diane, that I'm from Covered California, the state's marketplace exchange. What's important to know about Covered California is from our very beginning, our mission has been not just about enabling access to affordable care, but care to what end? And making sure that the care people receive is high quality, addresses equity, that we really support delivery system transformation. And that's really where primary care comes in, because we truly believe that the foundation of any high functioning delivery system that improves health is primary care. And so in that context, the dwindling primary care workforce is a real issue. For example, in our contractual requirements with health plans, including Rich's plan, we require that every enrollee has an assigned PCP. Ideally, they select it, but they also are allowed to be assigned a PCP. Obviously, if you don't have PCPs, it's hard for health plans to do that. I think another key focus area for us is behavioral health. And we know that some of the most effective models in terms of ensuring access to behavioral health is with primary care integration. And again, if there's no there to integrate with, it's really hard to make sure that our enrollees have access. So, we've been thinking about this a lot. We don't have a lot of levers as a purchaser to drive workforce directly, but we really are focusing in partnership with many other organizations across the state. California is a great place to be right now in terms of primary care, lots of people leaning in, including CHCF, but looking at primary care spend and how do we, to Rich's point, make sure that enough resources flow to primary care in order to make it a sustainable and desirable destination for providers.
And Diane, this is Catherine. You mentioned the issue on pipeline and the need to grow our workforce by number. We absolutely see that as a need. We also see a need to better match our primary care workforce to the population of California. We have 11 million Californians, that's more than a quarter of our state's population, living in a primary care shortage area. So that's a mismatch on geography. 1/3 of our PCPs are set to retire in the next decade. So there's a mismatch there in terms of interest to serve and need of the population. And while 40% of Californians are Latinx, only 7% of our physicians are. So big mismatches in terms of race, ethnicity, and language concordance, which we know matters for access, for engagement, and certainly for health equity. So some big challenges there.
And I would jump in, I think from the Department of Healthcare Services perspective, a lot of the challenges have been enumerated, but workforce is definitely one of the things that we are looking at very closely at all levels. So not just the provider workforce, but all of the support staff that are needed for true team-based care in primary care. Where we do have levers right now, we have loan repayment programs that are being run out of Department of Healthcare Services to incentivize people to go into primary care in underserved areas. We are working with some of our CalAIM incentive programs. CalAIM, for those of you who may not know, is our 5-year Medi-Cal transformation initiative that encompasses a number of different policy goals and objectives. But we're trying to tie workforce diversity into as many areas as we can, really recognizing that a key part of our health equity and quality strategy is having a workforce at all levels that really represents the diversity of our Medi-Cal population, which I think we can all acknowledge, in current state, it does not. I will also say, as a primary care provider myself, when we think to the really upstream, at least provider pipeline, there are clear inequity issues here too. We know that the primary care workforce is overrepresented by women compared to other medical specialties, resulting in worsening, gender pay gaps when you look at how much we compensate primary care providers versus other specialties. And I think thinking through all of those elements and where we're rewarding and incentivizing upstream students and providers to go into certain specialties is something we have to look at.
Thanks so much. I think that the Commission's work was really important in that it brought together educators and representatives of the healthcare system thinking together about, how do we develop these pipelines in the community colleges, for example, or how does the University of California do a better job of meeting some of these needs, and how does the private sector or the commercial sector or the healthcare sector contribute their knowledge and their expertise and help to build this workforce, not only for healthcare, but for the economy. So that was a good effort, and I appreciate that we still have these ongoing problems in California and challenges, and appreciate the work that you guys are doing in each of your areas. My next question, oh yeah.
Diane, sorry, I want to bring this workforce issue back to equity. The report cites, work done by Barbara Starfield 2 decades ago and by Sanjay Basu and his colleagues just a couple of years ago, showing that there is a relationship between primary care workforce density and mortality. So the erosion of workforce, particularly in rural areas, is troubling because it likely contributes to health inequities. And the shortage areas in this country, most of them have been shortage areas for 20 years or more. So none of the policies that we've really tried have put much of a dent at all into the shortage problem that we have. So this is something we're going to have to really work at. We note in the report, we're not only losing physicians, we're losing NPs, we're losing PAs from primary care because we have made it such a resource-starved place to work. So I just wanted to bring it back to the equity question, because it is not just about workforce and access. It is actually about equity as measured by mortality. Thank you.
Thank you. No, I really appreciate that. And I think some of the neighborhoods that are hard, or some of the communities in California that are hardest hit by the COVID-19 pandemic are the places where we would like to draw from, are the places that many of our healthcare workers come from, and there's that burnout and suffering that's happened there as well. So things have only gotten more complicated in this last year. Thanks so much for that point. My next question is for Rich, and it really gets to this community-based primary care, which is brought up in the report and really emphasized. I know this is tough and important work across silos to meet patients where they are, but I also know that LA Care has really worked to make some progress in this area. Can you talk a little bit about some lessons learned?
Yes, hi, thank you for the question. So one of the things we've been doing since 2007 is we established our first family resource center in a densely populated part of the county where there were many uninsured and underserved individuals and a high density of Medicaid eligibles and Medicaid beneficiaries. Since that time, the family resource centers have expanded. We now have 7. We've also partnered with Blue Shield of California and with plans to have up to 14 by the end of next calendar year. There's a reason why we place these family resource centers, now we call them community resource centers, in the community where our members live.
Mm-hmm.
And it's to bring access to services and resources where people live. We've always provided services for both members and non-members in our centers. And increasingly, we're also adding some member-only services, things like telehealth access points to increase access to get their clinical care. We also do screening for social determinants of health and referrals to resources people may need. We're also deploying our care management team to those resource centers so that we can do more face-to-face, community-based, targeted care management. Some of the lessons there are the community has been so welcoming. We've established ourselves as a partner in the community. Some of our centers are in shopping centers. They're always located along bus lines for ease of transportation. We invite community-based organizations in to our centers. So our centers have become a part of the community. The needs are so great. So those partnerships have really flourished, and we look forward to opening the additional centers. The other things that we've been doing we talk a lot about adding value to our providers and our members. And not surprisingly, it's actually really rewarding to see some of the work that we're doing align very well with what the report has highlighted, doing additional work in access, payment reform, practice transformation, and our own workforce initiatives that align nicely with some of the work that the state is doing. We have an Elevating the Safety Net program where we're providing medical student scholarships to medical students that are looking that demonstrate an interest in serving the underserved in primary care in Los Angeles County. In addition to the medical student scholarships, we offer employer subsidies for existing practices serving the Medi-Cal population to bring in new physicians in primary care. We've also added psychiatry to the eligible workforce program. We offer loan repayment, and we've also funded new residency training program slots. So I'll stop there, and I'm sure there's more we can address down the line with the additional questions.
Does anyone want to weigh in on this? How do we incentivize these kinds of activities? We appreciate that LA Care is taking the initiative and doing this, but how do we, at the state level or a policy level, create more incentives to see more plans engage in these kinds of activities?
I can say, from the Department of Healthcare Services perspective, as Rich knows, this is not easy work. It takes time to build those relationships, to support community-based organizations, to contract with and support beneficiaries on the healthcare sector side. So as many of you know, through DHCS's CalAIM initiative, we are expanding benefits to include in lieu of services, which is a suite of services that will pay for non-traditionally covered care that is critical for health outcomes, things like transportation, housing, medically tailored meals, asthma remediation, as well as enhanced care management for some of the most vulnerable populations. And as we roll that out, community-based organizations and people who are really enmeshed in our communities are critical to that network of service delivery and really getting healthcare and meeting the needs of our members outside of the four walls of a primary care clinic. Obviously, many of these are still in pilots, but I think we are going to learn a lot of lessons about what works or doesn't work, but that, the money and investment of that definitely needs to be present and is certainly coming from the state level in California.
Diane, I would jump in and say, I think this is an area where I'm really worried about the disconnect between policy and practice and program, where I think we're all aligned in knowing that health-related social needs absolutely need to be integrated into kind of a larger approach from the healthcare sector. And at least from our vantage point, with 11 health plans, and even though we have the regions, we have some hyper-local plans, we have some regional plans, we have some national plans. And a lot of the work that Rich is talking about is predicated on, I think, on multiple things, but certainly on understanding your community well. And from a health plan perspective, if you're a national health plan, how well do you understand that local community? You know, what level of granularity do you need? And then secondly, we really worry about mandating things to our health plans, who then use this as a differentiator, have their own flavor coming into the practice and the CBOs, and really causing a lot more diffusion, fragmentation, administrative burden, and in the end, you know, mistaking activity for progress. So I think we are really interested in figuring out how to use whatever levers we have to move this these issues forward, but we have a lot of trepidation about unintended consequences.
And Diane, one thing that I'd like to add, I meant to mention it in my initial comments, is in practice transformation, we had a really excellent and successful national model with the Transforming Clinical Practice Initiative out of CMS and the Center for Medicare and Medicaid Innovation. LA Care was one of 3 highly successful practice networks here in California. I'm a native Angelino and proud Californian, so I'm happy to boast that our 3 practice transformation networks were 3 of the highest performing in the nation. I would pitch that, you know, it was a successful pilot, but where is that funding now? So one thing that we're doing at LA Care is we're doing our own practice transformation we call Transform LA. We're funding it ourselves, and we are offering technical assistance and practice coaches following the model that we used during the Transforming Clinical Practice Initiative. I would suggest that if there were another round of federal funding or state funding to help plans and provider groups fund this really essential practice transformation, because we did produce better outcomes at lower cost using that model.
Thank you for that. Anyone else want to comment on the challenges of practice transformation? I kind of want to get to the next question, because we in primary care always say, oh, it's not about the money, but you raised the issue here. What we know is it's all about the money, right? And so I wanted to turn to Catherine and pose a question that was posed to us by Alan Glasseroff, who's on the call today. And he said, while we have known how to change primary care in the US for 3 decades, we have lacked the will to change payment models and expand the percent of premium that goes to primary care. What is different now?
So it's a great question and a timely one. Real estate agents always say that what matters is location, 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 and health policy analysts will tell you it's timing and leadership. And I think on this issue of payment, actually all 3 factors are important. So Alan's exactly right. We've known how to deliver high quality primary care in the US for a long time. And as Bob noted, we've seen effective models and bright spots all across the country, including here in California. And I've had the privilege to visit several of them all across the state. And unfortunately, payment systems to support that care have lagged. Now, I think to be fair, value-based payment models are now widespread, and every year we see more and more dollars flow through them. But they still aren't the predominant form of payment, and most don't actually change the way individual primary care providers are paid. They certainly haven't equalized salaries relative to debt load. We heard that from Pallav earlier, and we know that's a major barrier to our pipeline and workforce expansion goals. And perhaps even more importantly, while value-based payment models do reward quality and many other outcomes that we all want and need, they don't on their own necessarily result in more resources directed to primary care. Even some of the shared savings models we've seen have proved pretty meager in most cases. So I think the NASM report really wisely called out that to advance high quality primary care, we need payment models that change the way we pay for care, right? That's moving from fee for service to population-based models, and the amount we pay, and that's investing more of the healthcare dollar in primary care services and supports. I think I'd bet that all the folks on the phone today believe in the power of a primary care-centric healthcare delivery system. I certainly do. And I think the question Alan's calling out is, are purchasers and payers really ready to join us in that vision? And I think they're close. So the question is, what's changed? And I would highlight three things and welcome reactions from my co-presenters here today. The first is timing. And I think there's really a new sense of urgency around primary care. Diane, as you mentioned, COVID-19 shone a bright light on the fragility of primary care that's caused by decades of underinvestment. And frankly, I think many purchasers, policymakers, stakeholders took primary care a bit for granted, just like payers or parents, I should say, took schools for granted. But when COVID hit and enrollees or their own families couldn't get in for routine care, that perspective really began to change. And we certainly saw when testing and vaccine rollout, vaccines became available and primary care was instrumental in rolling them out, primary care went from an afterthought to really a lifeline. During lockdown, we saw reports from all across the state about layoffs in primary care, practice closures, even among our federally qualified health centers. And those reports captivated attention. They really got some political capital. So that's one. Second is leadership. At least here in California, we see a new willingness to align payment efforts, to align measurement efforts. And that gives me great hope that real change is on the horizon. Blue Shield's been a leader in this, the Purchasers Business Group on Health, Covered California, IHA, and many others. I think there's also now clear models, both for practice transformation and for payment redesign. Groups like the HCP LAN have been gathering evidence really over the last decade on payment mechanisms, what works, what doesn't, where the limits are, and we can and we should learn from that. And was noted earlier, there are now 11 states that have pending or active legislation or regulation either to transparently share primary care spending, and a few to actually increase spending by setting a target or a threshold. We've been following those experiences closely, are looking to apply some of those similar solutions in California, and hope we have time at the end of the call to hear from the group on some next steps in that area. And last is location. That's my real estate reference. We've run out of other places to go and other ideas to try, which I actually think will make potentially some very tough conversations on resource reallocation, which is what we need, much more palatable. We've seen experimentation with network design, benefit design, case management, technology, what have you. And as Bob noted, none of these innovations have actually yielded better population health outcomes or improved health equity. So just as one example, among Medicaid managed care enrollees, we saw quality either stagnate or decline for over half the measures tracked by state health officials over the last decade, 2009 to 2018. Even well childcare. That's pretty disturbing. So as the NASM report stated, the only change that promises to improve population health outcomes and health equity is better access to high quality primary care. So I'd argue it's time to go there. And I think there are many more in many more categories, areas, stakeholder classifications, however you want to count them, that are ready to join us than there were 5, 10, 15 years ago.
All right. You've convinced me that now is the time. Bob, did you have your hand up?
Yeah, it's always dangerous to follow Catherine because I want to endorse everything she just said.
Yeah, absolutely.
I want to point out in the report, we talk about how we're not going to tweak our way to this. Mm-hmm. But if you look at the half dozen states that have already enacted through legislation or through policy, increasing the percentage of total healthcare spending that goes into primary care, there are models for us to follow, and the report recommends that we increase the funding into primary care by at least 50%. That's not a tweak. That's a major investment. Mm-hmm. And if you look at some of the all-payer model states that CMS has authorized, some of them offer some really potent lessons. Maryland, for example, has not only increased the revenue flow to primary care, they have pushed down on the revenue models of hospitals, so that it creates two pressures to change the redirection of focus to primary care, because the hospitals lose their attractiveness as a revenue center. And the strategy for reaching margin is to lower your cost more than your revenue. So that's a primary care strategy. And so it really has enhanced primary care in Maryland. The last thing I'd say to Rich's point is that there is authorizing legislation in the Affordable Care Act for practice transformation support. It's in the Primary Care Extension Program, and that's what authorized the program Rich mentioned and the one that the Agency for Healthcare Research and Quality launched. And you see several states like Maryland, like Vermont, that are channeling some of those additional primary resources, primary care resources, into helping practices make these changes and to build out shared resources like social services, like mental health, so that even small practices can take advantage of those mechanisms for expanding their comprehensiveness.
Mm-hmm. I second everything that Bob and Catherine said. I would just add, I think on the measurement and metric front, there is a lot that could be done in this space to help support these arguments. So, what are the fiscal measures that we are tracking around primary care spend? What do those benchmarks look like? What do best practice rates look like for primary care providers and reimbursement relative to, other types of utilization, specialty, or inpatient? And how do we drive all of our healthcare systems and payers to close those gaps, I think, is an important thing that we don't track on an ongoing, regular basis. That the more we can bring those measures to light, the more effective these changes will be down the road.
And to share some of the work we're doing exactly in that area, we've been working with IHI looking at primary care spend and its relationship to quality. Again, preliminary analyses, but the range is quite remarkable. It spans anywhere between 4 and 14%. There does seem to be a pretty clear correlation between at least getting from that first quartile to second quartile, getting a big bump in all the kinds of quality, access, outcome, even some of the cost measures that we'd be looking at. So I think what's a little bit frustrating about this space is, on the one hand, those of us who are primary care believers and have spent our career here know that there's so much evidence for investment in primary care vis-a-vis, both outcomes writ large and small. And yet, in terms of actually being able to put in policies like a spending floor or target, we're still working on the data. We're still working on the justification. But part of it is also the socialization and getting our health plans and practices used to thinking about, how do we measure primary care spend? And that we're going to track it, and that we are going to actually relate it to quality, and in conjunction with that, really lean on outcome measures, which I hope we'll talk about later. And the last point I wanted to make is, a lot of the work we're doing in this space, we're doing very intentionally with Medi-Cal, CalPERS, other large purchasers, because again, for two reasons. One is Cover California alone is only 1.6 million Californians, compared to 13 million of Medi-Cal. But I do think, again, cutting through that noise and sending a clear signal to both the health plan community, the payer community, and the delivery system community is something that has to be front and center for us. Otherwise, I think it will just, again, be administrative burden, driving people crazy with a whole panoply of payment models and measures.
Well, and Bob said it's not enough for an incremental change. It's really a fundamental change, and that requires everybody all in.
I think the other thing we have to start looking at is, the return on investment for primary care is not one that is going to be seen necessarily in 6 months or 12 months. It is decades later when we have averted disease, averted bad outcomes, improved mortality, and many of our measurement structures are not set up for that longitudinal analysis. But certainly, at the state level, if we really care about what the health of Californians looks like 10 years from now or 20 years from now, we have to solve those problems now.
Mm-hmm. Do you think we're ready in California now to pull together a leadership? Maybe Bob, you can comment on the the recommendations in the report for a Secretary's Council at the federal level and some of the work you're doing there, and how that could translate potentially to a state as large as California.
No, sure. Thanks, Diane. So the Secretary's Council idea really came from the fact that primary care was not in any of the national epidemic plans. So it was not part of the strategy or strategic thinking around how to deal with the pandemic. And that's obvious not only on the administration side, but in what Congress did to try and create relief efforts. And so primary care, I think, suffered tremendously, as many people have mentioned here. But the greater tragedy is that it was not able then to be a mechanism to help manage what's happening in our local communities, or even just to convince people to take the vaccine. So the idea of this is that you would have an interagency council that worked across HHS to make sure that primary care remained in focus, and that it wasn't just the Health Resources and Services Administration dealing with federally qualified health centers. It wasn't just Agency for Healthcare Research and Quality studying issues. It wasn't the Substance Abuse and Mental Health Services Administration focusing on mental health. It's how do we work across all of them to address the needs of the population, and how do we help each of them help each other in doing that? And so that's the goal. And I think there's a good argument for states, especially as large as California, to have that kind of focus within government. It doesn't create a lot of new resource need. It needs time, and it needs communication. The second piece that we put into that implementation plan was a scorecard. So creating accountability metrics for government about how it is dealing with primary care becomes important for tracking this over the long term. Even at the federal level, all agency heads are focused on the fire in front of them. They're not focused on what do we need 6, 12, 18 months from now. It's really hard for them to stay focused on that. So having a scorecard that helps them keep track is something I think California could do as well, particularly since you all collect so much population data that could help populate a scorecard.
I think that's a good next topic. Can we move to accountability? Because I think that would be part of such a group. And let's talk about both these concepts together about, is there some sort of a need for more leadership in California at this moment in time, and what would be the accountability structure, or is there some sort of a scorecard? I know, Paula, you've been involved in a lot of quality measurement, and I'm curious if you have anything to weigh in about tracking primary care progress over time in the state.
So I think first and foremost, I am so grateful for the leadership that exists across the state. So our Department of Healthcare Services, Covered California, and CalPERS have regular joint meetings where we are thinking through how do we align our contracts, our delivery systems, our goals, and our objectives. And primary care and preventive care is a big part of that discussion. And I think, Alice, correct me if I'm wrong, but collectively we pay for about half the state at this point. So there's a huge impact there in terms of our alignment can push some of these initiatives forward, what it means for Californians. I think on the measurement side, as Alice said, having very strong, clear outcome measures that really support strong primary care practices and reflect team-based care is critical. On the adult side, I think we have more of these, and we recognize for children, there are huge gaps outside of immunizations. There really aren't great clinical outcome measures that we're tracking. I think for the Medi-Cal population, we recognize that, the outcome measures are great, but we continue to have such significant access issues, many of which Rich outlined earlier. Our networks are unevenly distributed. We see clear variation both in terms of access as well as quality and outcomes based off of the geography of the state. Even by zip codes, certain neighborhoods have much less access than others. That was laid bare in the COVID pandemic, and many of those access barriers certainly track along racial and ethnic lines. So I think as we start to think about what are the right metrics to really assess primary care, I think we need some of those process measures around access, around implementation. Where is money going? Where do we have an adequate, well-trained primary care workforce? Where do we still have shortages? Because all of those obviously feed into what the final clinical quality outcomes look like.
Alice, I wanted to ask you from your perspective at Covered California, a question that came in through the registration process. And it touches on this topic of measurement and accountability and sort of what's the quality that we're doing and really the inequities that we're seeing in our system. But it says increasingly primary care seems to be evolving into two systems: federally qualified health centers and safety net providers on the one hand, private or academic hospital related on the other. Is this optimal from the perspective of cost, quality, and accessibility goals? Are primary care initiatives available? Are policy initiatives available to promote more equitable community-wide primary care growth? And so I guess the question that I often am asking is, are we really developing a two-tiered system here in California for primary care?
Yeah, okay, so I feel like I have to do one of those disclosure statements. I've spent my entire clinical career in FQHCs, so just that's out on the table. And I don't want to minimize your call out that, Medi-Cal is one of the lowest paying Medicaid programs in the nation. Don't want to discount Rich's mention that there may be a two-tiered system in terms of payment and access, but I don't know that there's a two-tiered system if in the delivery system. If you think about a safety net delivery system being those that take care of Medicaid and uninsured. And the reason is because there's so many Medicaid folks. I mean, honestly, like when you have 1 in 3 Californians covered by Medi-Cal, it's inconceivable that as many FQHCs as we have, as well as robust public hospital systems, that's going to be sufficient. And so it's interesting. I mentioned earlier that we're doing a lot of work, and Paul have mentioned it, like we're doing a lot of alignment work. And so in that context, and I'll just as a digression say, in pre-COVID times, I would describe Covered California primarily as a safety net trampoline. So people come from employer-based insurance, come to us, and then most of them go back to employer-based insurance. During COVID, we have clearly been a bridge. Employer-based insurance through Covered California, oftentimes leading to Medicaid, Medi-Cal. And so in that context, we've been really interested in understanding what is the network overlap between Medi-Cal and Covered California, particularly for those health plans like Rich's that participate in both programs. And in that context, we were talking, and it turns out that only 30% of Medi-Cal recipients have FQHCs and public hospital systems as their primary source of care. I mean, that means 70% of people are out there in these other places. And so I do think the question raises another answer in my mind, which is there are clearly different models of primary care in California, right? And I do think FQHCs, and again, I would say variation is the tagline of healthcare, right? No matter where you look, you're going to see variation. So, but within FQHCs, I would say there are a lot of exemplars of really high quality, high performance primary care. And that's not just because, I practice in an FQHC, but I think really the idea of whole person, community oriented, culturally and linguistically competent, population health management. There are a lot of those tenets that have been baked into the FQHC culture and world here in California. I think you have to, say the Kaiser word, because honestly, Kaiser cares for, almost a quarter of Californians. And I would say what's interesting about their system is primary care is kind of infused in their whole approach, right? They have a population health approach, first contact accessible, whole person, longitudinal. And then the rest of the primary care world is a total fruit salad, right? You have large, well-established, high-functioning medical groups. You have small and solo practices, people who are cash on the barrel. You have startups, you have venture. I mean, it's the whole range. And so I will say that our current thinking as a purchaser is that our role is to, because our interfaces with the health plans is to hold health plans accountable, again, ideally in concert. You're going to hear me say this every time, in alignment with other purchasers for outcomes. And by leaning hard on them, tying significant financial consequences to performance, it seems to me the only way you get to those outcomes is by supporting and partnering with your delivery system. And by actually investing in primary care and doing some of the practice support. If you can get it some other way, I mean, honestly, I want the people of California to be healthy, but I can't think of another way, as I think Catherine was saying, like, we've tried all these other ways. It kind of brings us back full circle. I think, again, I'm not sure about two-tiered. I do know that there definitely are access issues, as Paul spoke to, in Medi-Cal, but I do think that in some ways the safety net primary care model has a lot to teach other parts of the primary care system, and that frankly what we want to do is do some cross-fertilization.
I would just piggyback onto that. As someone who's spent similarly my entire career in the safety net, a big part of why I moved to California was to train in the California safety net and really found a professional home and a culture that values the way we deliver healthcare in our state that I'm so proud of, and invests in that, invests in our public hospitals, invests in our FQHCs. That being said, we know that many of those systems are under-resourced. And so I think when I think about what California needs, 50 years from now or 100 years from now, long after my career is over, I think there's things we can learn from our educational system. There's a lot being discussed within education about integration and how integration is one of the most powerful drivers for eliminating disparities in educational outcomes. And yet in healthcare, we don't talk about integration, right? And we know that Medi-Cal beneficiaries tend to be more Black and brown than other types of insurance across our state, tend to have higher proportion of burden of disease, later diagnosis, more needs, social needs, and social drivers of health. And if we aren't actively investing in that system, more than potentially other beneficiaries who don't have as many needs, it's hard to close those equity gaps. And so I think, to Alice's point, there's a lot that we are doing on the payer side around accountability, but the fundamental question of, if you have sort of a non-integrated system, are you equally investing the way that investment needs to happen? And I think those are some of the questions we need to answer if we're going to close these gaps.
Anyone else want to weigh in on that before we?
Diane, the idea of a two-tiered system, some of the folks on the committee began to believe we may have flipped, actually. FQHCs have had so much support from HRSA, particularly over the last 15 years, around practice transformation, around integrating behavioral health, dental care, your own paper and your own work showing that they seem to be incorporating more of the elements of the patient-centered medical home than most independent or even academic practices. And the fact that when it came to a primary care strategy for COVID, it was all FQHC because they have HRSA as a major federal agency at the table. There's some of us that believe that the two-tier actually may be leaning towards FQHCs as becoming the more robust model of primary care. And that actually is what helps stoke the idea of this Secretary's Council, is that we need to bring the other 80% of primary care into that kind of a supported system where we're not seeing this distance being created between the FQHC model and what primary care at large can deliver.
Yeah, and Diane, this is Rich. I was going to pass on this one, but just to reiterate what Bob and Alice were saying is, so in Los Angeles County, for LA Care members, probably 50% of our members are cared for in the solo and small group private practice space, rather than in our county, in our public hospital system or our FQHCs. And I think that it's true that there has been so much focus on public hospitals and FQHCs, where I think we need to remember is that so many people get their care in these smaller solo practices that don't have the kind of infrastructure or necessarily recognition to drive funding. So like in our transformation program, we don't exclude FQHCs, but we deliberately target the solo and small group private practices. And I think as we think about how to improve care for all Californians, we need to consider how can we collectively support those solo practices, small group and private practices, so we can, lift all boats, if you will, is raise the bar for all primary care providers. We need more, but we also have to do a better job leveraging what we have already.
Fantastic. Thank you so much. I want to go to the next question that, this is all related, but this one comes from our audience, and it says, integrating primary care and public health has long been seen as fundamental to improving the health of the population. But the COVID pandemic has revealed once again that we have a long way to go to full and effective integration. So, as we're talking about improving primary care and raising all boats and all the variation that's out there, is it also a priority to integrate with public health, and where do we see examples of where this is working well?
I'm happy to tackle that one from the state level. So I know our director at the Department of Healthcare Services and the director of the California Department of Public Health, Tomas Aragon, really see this as critical to improving the lives of everyone we serve moving forward. So our departments have very intentionally been meeting regularly, doing joint strategic planning, so that as our department rolls out CalAIM and all of the upcoming changes to Medi-Cal, that is being done in concert with our public health colleagues. I'm meeting with all of the local public health officers this afternoon for similar conversations at the local level. It's not the first of these meetings, but a series of them, because we really see this as the future. If we are going to really focus on prevention, strengthen primary care, that crosswalk and partnership with local health jurisdictions is critical.
And this is Rich. I would add, I think one of the things that we saw work really well as the COVID vaccine started to come out, great collaboration across the state, as Pallav said, and here in Los Angeles County with our Department of Public Health, and our FQHCs, certainly our hospitals and pharmacies. But the group that was missing earlier on in these efforts, there was not adequate focus on the solo and small group private practices. Later, as the vaccines were around, we did have a deliberate push and great partnership, including the Los Angeles County Medical Association and the California Medical Association, in partnership with the California Department of Public Health and our local health departments, to expand that network of COVID vaccine providers. Because as much as people can go to pharmacies or hospitals, one of the trusted sources of truth for people are their primary care practices. So that effort to expand the vaccine provider network, I think, is really important to close the gap. There's about 20 percentage point gap in COVID vaccine coverage between Medi-Cal beneficiaries and our county and state at large. So we know there's a significant degree of hesitancy, and we firmly believe primary care is one of those trusted sources of truth that can help with that.
Yeah, I will say this is another area which I think is so critical and so challenging. I just want to share with you that prior to COVID, the state actually recruited Tomas's predecessor, Sonia Angel, came from New York. And one of the reasons that I think folks were so excited about her is she had done a ton of work in New York integrating kind of public health and healthcare, mandatory reporting of A1Cs, getting eClinical Works into small and solo practices precisely because you could then get that data and do population health wrapping around, these smaller practices that were the bulwark of Medicaid in New York City. And I think, so one thing is when I think of like really interesting models, I actually unfortunately don't think immediately of something in California. I think of New York City, and that was like 15 years ago. And I think, I do think data has a huge role to play in it. I think some of the efforts around HIE and the roundtable that's been put together, I think is going to be critical. I think Paula's work, the DHCS, CDPH intentional coming together to figure out what are the touch points. But I just want to say, COVID is qualitatively different. I mean, I think COVID is really important. The vaccinations, are important, but like chronic disease ultimately is where we really need to figure out how do we marry a public health, population health approach and the healthcare system. And I think one of the fundamental kind of philosophical issues is we don't have a clear agreement on what does a private-public partnership look like. What is the role of the private sector versus the public sector? And I think those are some of the unaddressed kind of lack of consensus areas that trip us up sometimes when we try to move forward in this area.
We have a question from Tom Bodenheimer, who is in our audience today. And he says, a new office in the Department of Health and Human Service, which we all know, the Office of Accountability, was supposed to shine a light on primary care in California, but the office has apparently been delayed or worse. Can you talk about what this office could do, and will the office actually be created? Does anyone know? Nobody knows.
Well, I'm not unmuting myself to say I know, because actually, Catherine, you go first.
Yeah. I go first. All right. No one knows what will happen, but I can tell you what was intended to happen, at least in terms of what was made public earlier in the year. And that was the idea of an Office of Healthcare Affordability, the idea of both studying and increasing both primary care spending and, interestingly, behavioral health spending, which is unique compared to some of the other states that have used this model, was in that language, as well as many other opportunities to study and opportunities to set targets on global spending. And so that was really meant as a way to both set some statewide goals and achieve them on the broader construct of affordability of healthcare, and to begin that process of reallocating resources into where we need it most, primary care and behavioral health. The office was established and funded, but the governor, the legislature, and stakeholders were not able to reach agreement on sort of the technical components of it, which are very important. So those discussions stalled. They are supposedly restarting in January with our new legislative session, and I think we're all very hopeful that they will restart and move quickly. But not able to share more, and have learned my lesson on making educated guesses about what will and will not happen. But certainly something to follow. That is a tactic that other states have happened, and I think this ties back into a couple other questions about, how do you actually get traction? How do you put teeth in these goals? And we've seen in other states, whether it be through the Department of Insurance, through the governor's office, through independent councils or commissions that have such authority to do these things, whether it's to require transparent sharing of data on primary care spending or to set those targets or thresholds. It can happen. It is happening, but it is political, and it takes a lot of time to get the details right. And that's exactly for Bob's point. This is not meant to be an incremental shift. It's a game changer. And so everybody has to get around that same table and agree on the playbook.
Someone asked us to repeat the name of the office, and it's the Office of Healthcare Affordability is what we were talking about. Anybody else have any inside information about this?
Alice, did you want to jump in? But I do have something to add after you.
I think Catherine captured it really well. Just I was actually at agency when this was being formulated. I think probably many people on the call had input, and it was very much a California process. At the same time, we did look to Massachusetts, we did look to Rhode Island, we did look to Washington State, and then put it through our unique California filter. And it was really broad ranging. And, you know, and again, as Catherine says, it's not gone, it is political. You know, in general, I think, as you've seen with some of the cost transparency work coming out of CMS, it is not avidly embraced by many sectors of the many healthcare sectors. So you pretty much have most people saying, wait, like we don't want to shine a really, you know, harsh, bright light on this. At the same time, I do think with the HPD progressing, that is actually another critical part of this whole conversation. Having the HPD, having the policy aspects of the office that are not just about reporting on spend, including primary care spend, behavioral health spend. But the idea, as Catherine mentioned, was trying to start to measure and set some targets around primary care spending, behavioral health spending, and also doing what now the DMHC is, that acronym, Department of Managed Healthcare, is charged to do, which is create a parsimonious set of quality and equity measures for the state. And HPD is the Health Payments Database, which is our version of an APCD, All Payer Claims Database.
And you know, the one thing that I would offer, and I heard a briefing on this, and I wasn't certain it was public, and I heard some hesitation in some of my co-presenters' voices, but I'm reading it on the web now. So Tom, it's a great question. This doesn't necessarily directly address the question, but I think it's a bright light and a positive move in the state. And it's what they're calling the recasting of OSHPA, the Office of State Health Planning and Development, into what's being called the Healthcare Access and Information. And this recast that is to take place over the next couple of years has many of the priorities that we've been talking about today, with building the healthcare workforce, strengthening primary care, funding pipeline programs to increase the diversity of the primary care workforce. So I would offer look up OSHPA and HCI, the Healthcare Access and Information. I think there's some really promising work that they're planning there.
Mm-hmm.
So I think we're touching a little bit. I'm hearing folks it's easy to promote primary care and primary care spending until you get to the point where you have to acknowledge that there's maybe some winners and losers in this. And so does anyone want to comment on what those dynamics are like in California, or is that something people want to sidestep in terms of if saving money on the investing in primary care to save overall total spending may require some people to lose some money, and there's this feeling of not everybody's so pro primary care all of a sudden. Does anyone have any insights into how that's playing out?
Diane, you're asking tough questions. No, can't comment on that, but I will offer an observation, which is if you look at the other states that have been successful with the outcome we want, which is directing more resources to primary care, most of them don't start there. That's a harder argument to make. It is a more politically challenging argument to make because you begin the argument with the concept of reallocation, and right or wrong, it's just sensitive. The states that have been successful, and we've named a few, Rhode Island, Delaware, Maryland, et cetera, again, slightly different models, but I would lift them up as examples, have said, we can't spend more on healthcare. The amount we spend on healthcare is hurting our state. We don't have enough for education. We don't have enough for climate. We don't have enough for all of these things we care about. And so we need to set some cost targets to manage what we are spending. And so they start there. And then they say, we believe health will be better for our population by rethinking the way we spread those dollars. but they don't start at the spread. They start with the how much, sort of the cap. And not to say that's easy. That's a tough conversation too, but it's a less sensitive entry point, and it changes the dynamic from primary care versus specialists or primary care versus hospitals, many of which I think are really false arguments. It doesn't have to be that way. There are not always losers in these things, but sometimes it's heard that way, to thinking about where should healthcare fit against education, roads, whatever else you care about in your community. And that just opens it up to many more, people and stakeholder and voices, and it sort of tones down some of the controversy within healthcare. So I would think about starting from that frame.
Diana, I completely agree with Catherine. A lot of the states have started with how do we maximize our health outcomes for a limited investment in healthcare. Mm-hmm. The second way that many states have approached this are by defining primary care and estimating what current spend is. And in those situations, it's been fascinating. It hasn't been a loss of interest in primary care. It's a sudden interest in being declared part of primary care. And so it has been a necessary effort to get clear about what is in the bucket and what is not. And then estimating what our current spend is, which usually is an amazing aha moment about, wow, we didn't realize how little we were investing here. No wonder we can't integrate behavioral health. No wonder we can't increase access. So there have been a couple different very successful approaches that California could follow.
Along with our hard question. Oh, go ahead. Go ahead.
I don't know if this will be a satisfying answer, but, I think we can all recognize, no matter what specialty you're in, when I talk to my colleagues, no one thinks that the way care is being provided today is efficient, effective, or great for the patients. I talk to any of my emergency room colleagues and they will rattle off all the patients that came in that day who really did not need to be in the emergency room, but faced access issues, couldn't get refills on their meds, you name it. Same with my specialty friends. They see tons of folks where they end up being the default PCP because there isn't an adequate primary care network. And my cardiology friends do not want to be managing their patients' depression or GERD when they come in, and they really would much rather have that be in primary care. Mm-hmm. And so I think as we all collectively come together, I believe there is a genuine desire to make sure patients are getting the right care at the right place at the right time. And we do have, I think we need to think through what are the financing mechanisms that help support that alignment. What are the shared savings models that we can have? I think eConsult in California, which, Alice is the expert on, really has shown that. And now we have a reimbursement mechanism for eConsult within Medi-Cal where the specialist can get paid for providing advice to the primary care provider who can then keep that patient in primary care and not have to refer unnecessarily.
Gets back to what's the best for the people of California, and it's like in many conversations in medicine, what's the best thing for the patient? And sometimes going back to that is the first step forward. I have another question that I wanted to ask, keeping in line with our challenging questions. You guys are doing a great job, by the way. Where are there opportunities or leverage in California to align payers in the commercial market, where PPO and fee-for-service payments are prevalent, with payers in Medi-Cal, where capitation and delegated models are more prevalent? Compelling such different payers to align has been a major challenge, and that alignment is critical for supporting advanced primary care.
Well, I will jump in since I think I have used the word alignment in probably every response. But it's for real. We are truly, as Paula said, we're meeting every 2 weeks with CalPERS and DHCS. We also partner very closely with PBGH and CQC, IHA, really trying to figure out how do we come together. So for example, PBGH and CQC have developed an advanced primary care measure set that we are including in our contractual obligations with our health plans to really kind of hone in, again, moving away from more PCMH process measures to focusing on outcomes and just saying, get there how you can. We think we know how you're going to get there, but, just get us the outcomes. I think one question that always comes up, particularly for some of our shared plans, and I would love for Rich to speak to this just because there are a handful of plans that participate both in Medi-Cal and Covered California, or in CalPERS and Covered California, and trying to figure out if we are aligned, what are the barriers within a health plan to create synergy across their lines of business, given that so much of the measurement infrastructure, so many of the requirements are by line of business.
Yeah, it's a great question, Alice, and thanks for your comments. I think another part of the healthcare system that we have to add to the mix and complexity when we talk about alignment are the role of the IPAs, the Independent Practice Associations in California. We've all heard the jokes about California and the things we do differently than other parts of the country. But we are a highly delegated state, and even more so here in Southern California. One very promising opportunity is at that provider group level, because the IPAs have contracts with multiple health plans. They all have their own provider networks, whether they're centered around their own staff model medical groups or they're in fact independent practices. But they have multiple health plan contracts and oftentimes multiple different product lines for Medi-Cal, Covered California, other commercial products, and Medicare. So I think the promising thing is you mentioned alignment several times, and those conversations are robust at this point. There's a real focus, and one of the earlier questions Diane teed up for us is now the right time? And I think we've all heard the expression, there's no time like the present. And there is, I would say, more energy, enthusiasm, and focus on this topic now than I can remember over the course of my career. So I think that alignment with various purchasers, as well as some of our foundations like the California Healthcare Foundation and the Integrated Healthcare Association, the Purchasers Business Group on Health, the California Quality Collaborative. These conversations are happening now, and there is a significant effort to coordinate the efforts across all of the different entities. I've mentioned, Alice mentioned, Pranav has mentioned. So it's complex, it's challenging. It's hard enough doing anything within a single plan. When people start talking about multi-payer alliances or alignment, I don't know about other folks, but my head sure starts to spin. But I do think now is the time, and I do think we have to invest in that effort.
So we're getting close to time, and I want to be respectful of everybody's time. So I have a couple of things. One is I want to close by having everybody go around and just say what inspires you at the moment. And I think, Rich, you just did a great job. I want you to think about that for a second while I speak to the audience. And what I'd love, a couple of things. One is if you could, we have a one-question survey. And if you could complete the one-question survey, and the question really gets at your interest in having some sort of forum in California where we could come together across silo and across sector to talk about primary care, what that might look like, what you would personally want to get out of that, who would need to be at the table. That's just an open-ended question for you to weigh in on, and I would love your input. A second thing, I want to give a little plug for those of you on Twitter. Mathematica has been hosting, along with a bunch of co-host organizations since 2020 when the pandemic hit, a primary care Twitter chat, and it's just a lot of fun. The next one's going to be on October 14th, and the topic is primary care as a public good. So you use hashtag primary care COVID chat. Email me if you need to know more about it. It's just a kind of a fun event. It takes place over a 1-hour period. So those are my two little plugs. Who would like to go first and say what inspires them about primary care in California at this particular moment in time?
I'm happy to go first.
On you. Okay.
So I think, all of us would prefer that the COVID pandemic had not happened and that our entire nation and the world hadn't gone through what we have for the last 18 plus months. But I will say, if there was a silver lining for me, it is that we are finally having conversations about what true health equity looks like in this country and certainly in the state. And I think the most senior leaders in our state are helping us infuse that lens into everything that we do. And asking questions about what is the type of care delivery system and values that we want to have in healthcare. And so I'm inspired that this seems like a point in time where we really can make some of the dramatic changes that are clearly needed. And that, Bob was talking about, this is not an incremental change period. And if, it's now or never or at least now or never in my lifetime, probably. So that really is exciting to me.
Alice?
Paula and I are often on the same page. I would say the same. I think about, the silver lining of COVID, opening this policy window. We need to figure out a way to prop it up and shove as much as we can through it, particularly around equity and disparities. And I would say, and then on writ small or on a very tangible level, I think it's my patients who actually represent a lot of the disparities. I still have clinic on Friday afternoons, and it has been pretty inspiring how families have come together to support their loved ones. I practice at Zuckerberg San Francisco General in the San Francisco Health Network, and pretty much all my patients are people of color, low income, oftentimes limited English proficient, and low literacy. And I will say they are incredibly resilient, and they rely on our clinic and our team. And I think that it has shown both, how resilient our communities are and how important our primary care system is.
Bob and Catherine, you get one sentence. What inspires you?
The people in primary care, providers and patients always have. I'd say this moment in time, it's that it seems like the family of primary care champions is growing. And I think that's important to acknowledge. And as we discussed today, really important to harness.
Bob, quick.
This conversation and the people having it, you all have spent your careers studying and innovating in primary care, and you're now in leadership positions that give me hope that California can come together in some kind of organized way to take primary care much further, faster than we could have yesterday.
Wonderful. I want to acknowledge that the next questions up from the audience were about the Secretary's Council and some version of that in California. So as you're thinking about and putting answers into the survey question about how we're going to take next steps, keep in mind that maybe we're ready for some sort of forum in California. I want to thank the speakers for contributing your time to the panel and for all of your leadership in primary care, and the audience for participating today and all the work you do to make sure that high quality primary care is implemented for all people across California and across the US. Have a great rest of your day.
Thank you.